persistently trying to level up.
There were very few people, I think, that had the drive to work. And I think that's what made the difference for me. It's just persistence.
The one-size-fits-all approach is absolutely not the right way to do things.
Yeah, I mean, I look at myself as an educator. I'm educating them as to what their options are. Having that surgical experience in a broad variety of procedures allows you to do the routine procedures much more predictably with the least risk possible to the patient. I look at how my kids were raised. I look at how I was raised. It's almost like night and day, right? The challenges and the demands are so much greater now with social media and everything that goes on. The level of anxiety and complexity of relationships is so much different.
Dr. Nestor Karas. Wow, what a privilege to have you here, sir. Outstanding opportunity to speak with someone who I admire so greatly. Welcome to the show. And as you know, in this show, we have you pick the charity, and the charity that you chose was the Navy SEAL Foundation, which obviously is one that we appreciate and think is fantastic. So,
well, thanks for the invitation. It's a pleasure being always with you, Jock. And yeah, I think given that September 11th was just passed, I think it's a good idea to honor those who served.
Yeah, amen. You have had an incredible career. Truly, when we sit down to talk, it's one of those things where we can really chart this back. And I think the key thing probably here, in order for people to understand just how impactful your career has been, is to go all the way back to your origin story. Take us back. Where does it all start?
Yeah, well, I appreciate that. I'm not sure I would look at it that way, but I think what happened with me is I was very fortunate that I had a number of opportunities over the years that came my way. And I was either dumb enough or smart enough to take those opportunities and see where it took me. I didn't really have any particular plan, but it just worked out. But I appreciate those comments because that's very kind of you. So it all started out in Oakland, California. That's where I was born and raised. I went to elementary and junior high there, and then my parents moved to Contra Costa County to Orinda. I went to high school there, and then was fortunate to go to UOP undergraduate and UOP dental school in San Francisco. And I had an experience when I was in high school. I was your typical high school kid, didn't know anything about anything and didn't know what I wanted to do, right? So I went, my father had a good friend who was a dentist here in El Cerrito in the Bay Area, and he said, go visit Uncle John and see what you like, see if you like dentistry. And I didn't really have any particular interest, but I did. And Uncle John was one of those guys, we called him Uncle because he was such a good friend of the family. He was one of these guys that everybody loved. His patients loved him. He had absolute command of his practice. It was just a great scenario and situation. He was a great dentist, and he sent me to a number of specialists. I went to the orthodontist for a day, I went to the endodontist for a day, and then I went to the oral surgeon for the day. And when I walked into the oral surgery practice, I saw the buzz that was going around. The doctor was doing a sedation. I can't remember the case, but I looked around and I thought, seeing the monitors on one side and the anesthetic assistants and pushing the drugs and getting ready to do the surgery, I thought to myself, this I think I could maybe do. So, I was fortunate. I made that decision early on. So when I got to dental school, I knew I wanted to be an oral surgeon as opposed to, I'm going to kind of decide as I go through. So I was fortunate from that standpoint because of that early positive experience.
You knew your track going in.
I did. So I spent a lot of time hanging out in the oral surgery clinic and dental school. There wasn't a lot of time for extracurricular stuff at UOP because it's a 3-year program. But I actually did get a chance to go to University of Texas to San Antonio and spend a month internship, early part of my 3rd year. And I spent a month there on the service at UT San Antonio with their service, which was a great experience and an experience that I would have never been exposed to in dental school.
UT Southwest?
No, that was UT San Antonio. So I was
there. Okay.
But I was staying with a classmate from UOP who had graduated, was in the perio program there. And the Parkland program was in Dallas at UC Southwestern. And he said, if you're interested in that program, you should just go visit them for a day. I said, well, what do you want me to just go there unannounced? He says, no, call them the day before and say you're here in Texas and you want to just visit. So I did do that, and they said, well, you can come, but we're not going to really give you any particular tour or any special arrangements because you didn't notify us. So I flew up from San Antonio to Dallas and just walked into the hospital there at Parkland Hospital and was just immediately impressed by the volume of patients and what was going on there, just the mass of the facility. And then I went up to the oral surgery clinic, spent, half a day with the residents there watching them, basically do exodontia procedures. I went to one of the meetings that evening. It was a Wednesday night meeting, went to the meeting, and then I flew back to San Antonio. And although San Antonio is and was a great program, my goal at that point was to try to get into Parkland. Because I just was really impressed with the breadth of surgery they had there, the experience there. They had 3 separate hospitals. They had half a dozen faculty there that were at that time world-renowned, Bill Bell and Doug Sin and R.V. Walker and Bruce Epker at Ellis. I mean, those were the people that everybody wanted to learn from at that time. So I was very fortunate, very fortunate.
Yeah, when you drive by it, it's just like...
Yeah. I recently went back because my daughter went to TCU, right, for undergraduate, and so I called my prior chairman, who's now retired, Doug Sin, and we went out with him and his wife Diane to dinner with my wife Lillian. And at the end of the dinner, we drove by the new Parkland Hospital. So they have a new Parkland Hospital, they have a new research facility, and they actually have 2 brand new university hospitals that are more private hospitals that are supported by the faculty there. And it's just amazing what they've been able to build there. The resources there are just, it's really impressive.
Well, it's kind of like from a dental school standpoint, you look at UOP's new campus and it's just like, you just go there and you go, wow, it's on a whole nother level. Parkland is,
it's just great to see the progress that's happened there.
Yeah. So I think maybe one thing that could be really helpful for people is to understand just the disparity in training. There is a huge gap. When we talk about your level of training, oftentimes I think people don't really understand what an oral and maxillofacial surgeon, and I emphasize that for effect, really means. And I think if you could go through and explain what does that training really entail, because a lot of you're not using a lot of it probably on a day-to-day basis, but it does play into producing outstanding results and things that you do on a day-to-day basis.
Yeah. I pretty much do everything that I was ever trained in still today at Parkland at University of Texas. The only thing I gave up doing is trauma. So I did trauma for many years, over 20 years, both at the university when I was teaching and then also when I was in private practice at Jarmuer Medical Center in Walnut Creek. And although I'm still chair there of the department, I no longer take trauma call, but I stopped doing that about 5 years ago just because it became difficult to see patients in the emergency room and stay up all night and then function the next day as I got older. But beyond that, I pretty much still do full practice of all the things that I learned at Parkland. And I think training is... and when I was teaching and I would tell residents and I would always ask residents, well, what do you want to do when you go out? Well, Dr. Karas, I want to do this. I want to do implants, or I want to just do wisdom teeth. And I would tell them, I'd say, you know what, you may think you know what you want to do, but you have no idea what you want to do because you don't know whether that's really what you want to focus on, nor do you really realize what kind of community you're going to go into, because there may be a community where there are a number of people doing wisdom teeth, and there really isn't the demand for that. Maybe they need a traumatologist. Maybe they need someone to focus on orthodontic surgery or TMJ or pathology or a combination of all of those things. So why limit yourself? And it's the same thing with training, right? When you're looking, I think, for any young person looking at training in oral maxillary surgery, as you say, there's a tremendous disparity in not so much curriculum. Curriculum is standardized throughout all programs by CODA. But, that curriculum varies based on the attendings that are there at that particular time, what their level of expertise is, the resources of the facility. Are they connected with the dental school? Or are they not? What is their level of trauma? Trauma is the great equalizer in terms of training for young surgeons, right? So if you go to a trauma center, you're going to get a tremendous amount of experience, right? When I finished Parkland Hospital after 5 years of residency, I'd done hundreds of facial fractures, everywhere from advanced, really complicated orbital and mid-face fractures and hundreds of mandible fractures. So it was really second nature. And that's really where a young surgeon really learns their surgical skills. Okay.
Yeah. And for the viewer that doesn't understand what I mean, orbital fractures, So around the eye socket, cheekbone, and then mandible being jaw fractures, which, those are serious repairs.
So when I think a young person is looking at those residency training programs, it's important to get a breadth of experience. And once you have that breadth of experience, then that will carry on to you throughout your career, because you will see cases and you will see patients that you need to know how to treat, and you can't send them to the university or to other doctors in the community necessarily, particularly if you live in a more urban or rural environment, right? So that's the advice I would give to a young surgeon.
Well, and the other thing too, I think that people maybe don't know is that you have a general surgery portion of what you're doing. I mean, that if you could talk about that.
Yeah, that's an interesting story. So, I went through 13 years of postgraduate education, right? And I don't say that to scare people away. That's just the way it worked for me, because at the time that I was applying for oral surgery programs in 87, 86, 87, so it was quite a few years ago, there weren't many dual degree programs out there. I did interview at one dual degree program, and I decided it was not my top choice because you spent so much time in medical school and then general surgery training and very little time in oral surgery. The Parkland program that I decided to go to was not a dual degree program when I started. And as I was about 2/3 of the way through the program, they created a dual degree program. And at the time, I really wanted to go in academics. I was really inspired by my chiefs and my mentors there. And I wanted to go in academics, which I did. And I was told by the faculty there, if that's what you want to do, then you should really think about going to medical school and getting a medical degree. So I was going to do that. I applied. There were several medical schools throughout the country that would take people like me that had finished dental school and oral surgery training and give them advanced standing, as opposed to doing all 4 years. You would do anywhere from 2 to 3 years. And I was going to go to University of Alabama, had a good program that was well established for people looking to get dual degrees. And I was going to go do a 2-year program. As I was getting close to finishing my chief year at Parkland, Doug Sin, the chairman at the time, called me up a month or so before finishing. He said, "Hey, Nestor, we have an opening because one of our incoming residents decided not to take the spot because they only had 5 spots for the University of Texas for Southwestern Medical School. Do you want that spot? I'll sponsor you to apply." And I said, "Yeah, absolutely." Because I was married. My wife was working in Dallas, her family was from Dallas. So not having to move, even though I had to do an extra year, it was a 3-year program, made a lot of sense. And I'm glad I stayed there because it was a great experience, great medical school. It was interesting to go from chief resident at Parkland, where you're basically running a service, very busy. I mean, Parkland in the summer at that time was probably one of the busiest trauma centers in the world, to put it in perspective, right? And then go a month later, be a medical student, a second-year medical school, and go into class and learning how to do blood pressure and take vital signs, But, you take it with a grain of salt, right? That's part of the process. And so I met a lot of great people, and I had a great experience those 3 years. I was fortunate because I was able to get my Texas dental license, and I was able to practice as an oral surgeon part-time as I was going through medical school. So I kept up my skills and was able to make money to pay for tuition. And actually, before I finished medical school, I was able to get board certified in oral maxillofacial surgery because of that experience, right? So for me, it worked out. But after those additional 3 years, you're right, I had to do a year of general surgery training because I needed to do that in order to qualify for a medical license. Every state, you need to do a minimum of 1 year. And so the way it worked out for me, I applied to Parkland, and I knew a lot of the general surgery faculty and staff there to stay another year. But I also applied to other programs too. So I applied to Stanford, I applied to UCSF, and I was hoping to not do another internship year. I was hoping to do a second-year level training because you're not spending as much time on the floor taking care of patients. Second-year level, you're spending more time in the operating room, you're spending more time in the emergency room. And UCSF came back to me and they said, "Yeah, we would accept you at a second-year level to come and do what we call a PGY 2-year general surgery training, and you'd be working, at the county hospital at that time it was SF General Hospital. Now it's Mark Zuckerberg Hospital, and then also at Parnassus, right?
I mean, that's a heavy duty hospital.
Yeah, it is. And so that's what I wound up doing because after 8 years in Dallas, I thought if I stayed another year, I'll never leave, right? And I hadn't lived in the Bay Area for 8 years. I didn't know if I really wanted to live in the Bay Area again. And so this gave me an opportunity to come back and check it out. And, my wife came begrudgingly because she's a Texan and Texans are very proud of their state. But, she saw the light after we got here. And that's how that worked.
Yeah. So you're at UCSF now, and tell us about what's happening as you go.
Yeah, well, that year was, I think I did probably 5 months of trauma service at San Francisco General Hospital. So as a second-year resident, you're taking care of patients. You're admitting patients out of the emergency room. You're taking them to the OR under the tutelage of your chief resident. You're working a lot in the emergency room. You're doing triage. You're also doing floor work in the ICU. You're taking care of ICU patients. So, you're doing higher level stuff, certainly higher level care stuff than you would be as an intern. And that's what I really wanted to experience.
And to put it all in perspective, how old are you at this age?
Oh gosh, I'm in my late 20s, I think at this point. Yeah, late 20s.
So the reason I wanted to point that out is I want to articulate the intensity of this experience. Think about it. You graduate from high school, you go into your undergraduate, dental school, into oral surgery, then into medical school. That is the level. It's interesting that, your charity is the SEAL Foundation, because as in the SEAL teams, those guys are always trying to get to another level.
Yeah.
So it's just interesting, the intensity of the work that you did in that short period of time.
Yeah. It's interesting, and people have commented to me about that over the years. And I would tell you this, I enjoyed every step of the process, right? I loved the workload, and I loved the intensity of it. And I loved working in a tertiary hospital system. It's what I became very familiar with after all those years. Now, there are certain rotations that I didn't love, and certainly rotations where I wish I hadn't done. When you're on call every other night, when doing cardiac surgery at Parnassus, and you're sleeping in the hospital every other night for a month, that's not particularly fun. I wouldn't want to do it again, but I'm glad I did it because I think it made me who I am today. But on the same token, I enjoyed the process, and people say, would you do it again? I'd say, yeah, I'd do it. I would do it again in a heartbeat for sure. And I was just very fortunate that I had all these opportunities. And why? I don't know. Maybe because I'm just a stubborn individual and wouldn't take no for an answer. But it was a long process, and it's a lot. It can be done a lot shorter today. But back in those days, I was just trying to go each step of the way, trying to get into the best program, the best experience that I could. And I figured at the end of the day it would pay off. And I think for the most part it has.
Yeah, that's interesting. Your pathway to peak performance was persistence.
Absolutely.
Persistently trying to level up.
Yeah, exactly. I can guarantee you I was never the brightest. There were a lot of people that were brighter than me, but there were very few people, I think, that had the drive to work. And I think that's what made the difference for me. It's just persistence.
It's so funny. I always say, I always have to laugh whenever I hear anybody say that, especially of your caliber, I wasn't the brightest. It's just, I always think it's just humility. I mean, yeah, I've been around you enough to know how smart you are. And, but yeah. So, okay. Now you're in a teaching spot.
Yeah.
UCSF.
Correct.
And this is a formative, this is a very important part of your life.
Absolutely.
I love for you to share that.
Yeah. Teaching, that's really what my goal was. And my goal was not necessarily to go into private practice. I had no problems going to private practice. But again, I was so much influenced with my mentors at University of Texas that's what I wanted to be. I wanted to be like them. I didn't expect to even come close to their accolades, but I wanted to try. I wanted them to be proud of me, I guess, in some ways. And I tried. I gave it 4 years, and I would say that the experience at UCSF was generally positive. I was professionally very fulfilled. I was working in the craniofacial clinic doing advanced cases. I was running the dental facial deformities program with the orthodontics, and we were doing a lot of orthognathic surgery. I was doing a lot of reconstructive. I was doing a lot of advanced implant cases, working with the prosthodontic department for the ectodermal dysplasia kids and the cleft kids, and all those are all very challenging cases when it comes to dental implants and bone grafting. So I had a tremendous experience there. I would say what I didn't like or jive with was just the politics. I just could not navigate the politics of a university system like that. And every major medical center has its own culture, right? They have their own way of doing things. They have their own focus. Some are on clinical, some are on research, some are a combination of both. Where I came from, University of Texas, it was very much a clinical focused program. Yes, we did research, and a lot of publications came from that department over the year, collectively more than most programs. But, at UCSF, it was a different focus. Yes, there was the clinical programs, but the research was the main focus. And quite honestly, that was not my background. That was not my forte, and that was just not my interest. And it obviously became obvious to me that the only way to really advance in that system, not so much in the department, but in the system at large, because everybody pretty much has the same path for advancement, that you needed to do basic science research at a very high level. I just really wasn't able to come to grips to make that commitment.
Yeah, it's funny because Dr. Michael Longacre, his story is one where he was really pushed towards that.
Absolutely.
Yeah.
And he's, he was there when, we didn't necessarily cross paths. He was there working with the fetal surgery stuff and quite a pioneer in that, or extremely impressive individual.
Yeah. Great guy.
Yeah.
Good friend. So I want to rewind if we can, if it's okay with you, because there are a lot of terms that I think the average person, they don't probably really understand. So when we talk about orthodontic surgery, we're talking about moving the maxilla and the mandible. So the lower jaw and the upper jaw. These are complex surgeries that have to be done with such precision. And the reason I want to say that is that when somebody considers, like you talk about all the trauma cases that you've done, the orthodontic cases, the craniofacial deformities and cleft palate, cleft lip. I asked somebody the other day about, the advancements in closures. It was at a breakfast, and holy smokes. Closing a palate, then closing the lip, and doing it where the repair is, it's come so far. And these are major cases. What's beautiful about that is when you think about, I have a choice and I can pay the same amount of money to go see a general dentist to have my wisdom teeth. The general dentists are great. They're great. They're great for all sorts of things. But there's a nerve that runs down here, right?
Yeah.
And I'm going to have my wisdom teeth. Normally, most time the lowers, you're going to section them, right? To get them out easier.
Almost always if they're impacted.
Yeah. Uppers are going to come out pretty easy. But that nerve, that ability to get a CBCT, so cone beam, essentially a 3D image, and see where they are and know how to take them out and do it in a way that's with that kind of precision, it's going to produce such a better result for a patient.
Yeah.
The same thing holds true for implants.
Correct. Far be it for me to tell people what they can and can't do, right? That's not what I'm about. But what I will say is really the difference is as you described, right? Having that surgical experience and a broad variety of procedures allows you to do the routine procedures much more predictably with the least risk possible to the patient. I see a lot of complications in my practice because that's kind of what we see. We see patients that have had poor outcomes or have difficult cases that, other clinicians may or may not feel comfortable treating. I did a lot of that when I was at UCSF because that's kind of where a lot of people wind up that are either had complications or have difficult cases. But in the local community, I also have seen a lot of those patients. And I can tell you that in hindsight, when I look at those patients, they fall into two categories of mistakes that the non-surgeon has made. One is failure to diagnose, the correct diagnosis, and two, failure to understand where the pitfalls and increased risks are in terms of surgical positioning, surgical techniques. And then the third thing is how to manage those complications, right? And when I have people in my community say, I want to do implants, and they're a non-surgeon, I say, well, that's great. You can certainly do it. No one can say that you can't do it. But, you're going to be held to the same standard as I am when it comes to complications. When I have a complication, I manage it because I know how to manage it, and we can get patients where they need to be in terms of result, because everybody has complications. There's not a surgeon on this earth that is not going to have one. And the question is, can they identify it, and can they make the correct decision for the patient to rectify it? And what I see a lot of times in the non-surgical educated clinicians, either they don't recognize the complication, or B, they don't know how to treat it, and C, they delay in referral. And so it's kind of the trifecta of problem. And so that's what I've seen in my own personal experience, both when I was teaching and also in the last 25 years of private practice.
Yeah. I mean, so first things first, osteonecrosis. I mean, trying to understand like, hey, can you actually get an implant to sit in this? Do you need a bone graft? Do you need ridge augmentation? Do you need a sinus lift to make sure you're not perforating the sinus?
Right.
These are all like things that you can just pick off in a heartbeat, and that not everybody can do. And then also, I mean, talk about infection. I mean, sometimes people can wind up in the ER, and the only people that have the ability to admit somebody to the hospital is going to be an oral and maxillofacial surgeon. So ultimately, they're going to have to see anyway.
Yeah, that's true. I mean, if you look at the compendium of where we started with implant dentistry. So implant dentistry, when I was in dental school, you heard about implants, right? And they were being done behind closed doors by just a few people. The students weren't commonly exposed to that. When I got into residency, University of Texas was one of the first, Brandmark centers. And so Rick Finn, who is the chief at the VA hospital, took that on, and that became, the center for implants. And, we were working with a prosthodontist at that time, and our understanding of how implants worked, I mean, very different than what they are today. Every case was done in the operating room. We weren't using guides. We weren't considering restorative options or final restorative plan. We were basically just putting implants where the bone was, and we were hoping that they would work. And that was, late 80s, early 90s. And here we are at 2025. Implants can be, I mean, it's like what we're doing today, we weren't even thinking of or dreaming of back then, right? But along the way, we've made errors, and we've learned from our mistakes and our complications based on materials and selection and what have you. And now we have amazing materials, both from the reconstructive side in terms of bone grafting, and also from the dental implant side. And I think that the mistake that a lot of young clinicians make is that they don't know where we came from and the mistakes that we were making in the 80s, 90s, and early 2000. And I see a lot of them making the same mistakes now. Implants in the wrong position, implants poorly angulated, implants in inadequate bone, inadequate soft tissue coverage, angulated to the point where they can't be restored. It's the same mistakes that we were making 20 years ago, and we've learned from those mistakes. And I think that's what the novice implant surgeon has to deal with. You can't just go to a weekend course and learn all of those decades of experience and expect to get similar outcomes. And I think that it takes a tremendous effort. And, for many years, even in oral surgery, our concept was, well, implant surgery is easier than orthodontic surgery or trauma reconstruction or bone grafting or cancer or, removal of large tumors or cysts. But the reality is sometimes the easiest things are your biggest complication, right? You just never know, right? And what I like about implants is that in oral surgery, we're oftentimes taking things away. We're taking teeth out. We're taking out jawbone. We're trying to fix a trauma case, but in that process, the patient loses gums and soft tissue and bone. And with implants, we can actually give things back. So that's a huge benefit for patients. And it's something that as I get later in my career, particularly enjoy, is being able to give them to structure back, because it really is a quality of life issue.
Yeah, I think one of the things also people, when we think about people who have lost some of their dentition, the pressure on the jawbone, missing a tooth in some place, it starts a cascading effect that people don't really often understand.
That's correct.
It can affect the way that you look. Eventually, if you become a dentulous, it's pretty, I mean, that's why those all on X cases are what we call full arch restorations, where you're placing whatever the number of implants are that are required. And then you put the prosthesis on. It looks like, holy smokes, these people have the best looking teeth you've ever seen in your entire life.
Those procedures can be life-changing for a lot of patients, for sure.
Yeah. As are the orthodontic. I mean, I think...
Absolutely.
When you see somebody who's got a jaw that's just so far forward or recessed, and you're able to actually correct that. I mean, I've seen that may be one of the most dramatic.
Yeah.
I mean, obviously the cleft palate, cleft lip stuff is.
Yeah. No, with orthodontic surgery, I mean, not every patient gets a huge night and day result difference, but a lot of them do. And it's dramatic and remarkable to see that. And it's really, as a clinician, it's really great to see that for patients.
Talk about, if you would, total joint replacement on TMJ, TMD. So, I mean, this has been something that's been an issue for people for so many years. It's just so uncomfortable.
Yeah.
And I remember, Dr. Leonard Caven talking to me about, the failures back in the day that were with the total joint replacements.
And those failures were significant. So to the point where, fortunately, I was at a point in my training career where I had missed that decade prior where total joint replacements were very popular. And again, the clinicians were using the Proplast Teflon implants and others, and unfortunately they all failed. And they all created significant problems in terms of bone resorption and joint fibrosis. And almost all of those had to be removed, and the patients were reconstructed. Unfortunately, the FDA pulled those devices, and for many years we had no devices, and so we were using ribs or a combination of rib and iliac crest bone grafts to reconstruct the joints. And I did more of those in my early career as a trainee, and then also when I was teaching, than I actually did any of the prosthetic joint replacements, because again, they weren't really available for a long period of time. I have done several over the years. I don't do many open joints anymore, and I certainly don't do joint replacements. My partner does those now. But there are better materials now. But what I see is a resurgence now in that discussion.
Mm-hmm.
And I think that for the right patient, it's great. Unfortunately, what I see is that oftentimes the idea is, well, it's either all or nothing. Either we're going to do a joint replacement on this patient, or we're not going to do any kind of procedure. And I think that that's probably not the right approach necessarily. That's my opinion. Because the problem is, once you have a joint replacement, that's what you're going to have. So when that joint replacement fails, you're going to have another joint replacement. And the problem is, even the ones that we have on the market have really not been on the market long enough for us to do that 10, 15, 20-year study in terms of looking at what the progression is for those patients. So I think it's an area of caution. And I think that for the right patient, it could be a godsend, and it's the right operation. But what I tend to see is that maybe it's a little overprescribed at the moment, and there's a resurgence in the interest in doing that. There are certainly benefits to patients that have severe condylar resorption, have fibrous ankylosis, have open bites as a result of condylar resorption. Those types of the patients, that's what those devices were designed for. But your typical patient that has, some form of early osteoarthritis that has a malocclusion can be treated, I think, more conservatively with other surgical techniques. That's just my opinion.
Yeah, well, it's a good opinion. I was going to ask you, I'm just curious, if you were going to tell somebody, there are two things I want to ask you, but if you're going to tell, there's a mom. We all know that 80% of all healthcare decisions are made or influenced by women, right? At the end of the day,
Absolutely.
Probably in your practice, what you see are like the moms are coming in with their kids, and
Absolutely.
So they've been referred by the general dentist or the pediatric dentist to come see you and have the wisdom teeth extractor or orthodontist, whatever. If you're going to tell a mom something that, what's the one thing that they really want to know about wisdom teeth extraction that,
Well, I think there's two things. They want to know about the anesthesia and how that's going to be provided, and then they want to know about recovery and risks. And I think that those are probably the two most common questions that we get. I think they realize that their child needs to have the wisdom teeth out. I think oftentimes the dentists and the orthodontists do a good job of explaining the indications for why. I see very few patients that come in and they say, I have no idea why I'm here, right? And because they've been well educated by the general dentist or the orthodontist, or in some cases the periodontist, as to why these wisdom teeth need to be removed and at what age. I think that anesthesia is a big question mark for them. And that's something that we talk a lot about options, because I think it's important for patients to know they do have options. And then again, recovery and then risks associated with the procedure. And, fortunately the risks are low, but they're there. So we spend quite a bit of time going over those and how those might be managed.
So when you think about the anesthesia options, that's oftentimes people don't really know, actually, general public doesn't know that you're in your residency outside of anesthesiologists. Oral and maxillofacial surgeons are the only doctors that are qualified to provide anesthesia that would put you to sleep in an office setting. That's a big deal. I mean, I think the notion of being able to go to sleep rather than, I don't want to put you on the spot. If you don't want to get into this, don't. But how many times have you had a general dentist call you and say, "Hey, I've had the kid in the chair for 2 hours and they're local and I can't get the teeth out"?
Yeah, a number of times.
So when we got to think about patient experience and what that means to a patient, and they got to leave that office, they got to come over to you, and then you get the luxury of taking out the teeth quickly and then having the patient remember the bad experience was tied to you.
Yeah, there's no doubt about it. I mean, that's how I'd want my kids to be treated, and so I think the addition of being able to provide, a deep conscious sedation or general anesthesia is a huge benefit for patients. And I think it equates for a quicker recovery too, right? Because with them asleep, I can work faster, and I can give less local, and I can get the surgery done quicker, less traumatically. And therefore there's less pain, less swelling, and a quicker recovery as a result of it.
Yeah, I once asked somebody, what do you feel is like the true competitive advantage that an oral maxillofacial surgeon has that wasn't like an advantage. It was more of like, what's the benefit to the patient? Like, hey, we can just provide a less traumatic overall experience for the patient that gets a better end result.
Yeah. And what's happened, over the last 30 years is our medications that we're using now are much better than they were 20, 30 years ago. So now with propofol, we're using if any narcotic anymore. And so with propofol and Versed, we're able to sedate, 95% of patients very, very comfortably. And there's 5% of patients that are going to be resistant to those medications. And maybe a general anesthetic, like in a hospital, is a good option for them. And that is an option. It's an option to go to the hospital and do those cases. It's even an option for us to bring in an anesthesiologist into our practice to do that for the patient, and then we can focus on the surgery. So again, I think it's important that patients know that they do have options now, and because not one thing fits every patient, right? So it's important to have those options.
It's one of the things I really respect about you is that you're trying to inform the patient how to make the best decision for them, and recognizing that the one-size-fits-all approach is absolutely not the right way to do things.
Yeah, I mean, I look at myself as an educator. I'm educating them as to what their options are. I always tell patients, I'm not going to give you an option that I don't think is going to work. Right? I would never tell somebody, let's do it this way, thinking, well, this has a low chance of success, right? I'd only give you options that have similar to equal chances of success, but it's your decision to make that decision and what's best you feel is best for you. I wouldn't give you an option if I wasn't willing to do it and wasn't best for you, right?
Yeah.
I think it's important.
I think what's also interesting about your practice is that you're in Walnut Creek, so dental implants in Walnut Creek, California, right?
Right.
But you're not just seeing people from Walnut Creek, you're seeing people from all over. I mean, it's Concord, Pleasant Hill, probably, as far south as people, your reputation's so big that you're getting people from, probably down San Ramon, Dublin, all these different areas that people are coming to see you from. And I think that's just really a testament to the reputation and the way that you actually conduct your practice. I remember when I first met you, I was so impressed. After all these years, you get a sense of who's really great.
I appreciate that. That's very kind words. As I tell my staff, I try hard every day, right? That's the best I can do. Try hard every day and show up and be present and try to treat patients with respect and try to give them options for surgery, I think that's my job. And like I said, I've been very fortunate. I had excellent training, and I had a lot of great mentors that helped me along the way. So that made a big difference for me.
That's kind of just goes back to this story. Your pathway to peak performance again is like a steady climb out. You're one of the more even keeled people that I know, and you really just kind of keep staying on, and you have not compromised. You stay on your game all the way through. We talk a lot about practice. I would like to discuss things that I think are important for young people to think about as they consider a career in healthcare.
Yeah. Yeah.
What do you see as the future for people in healthcare today?
Yeah, that's a good question. A lot of people, both that are in healthcare and out of healthcare, peripherally involved with healthcare, are asking that same question. It's tough times right now. There's a lot of changes going on right now. And I think that um, as young people come out, sometimes they don't have a choice, which is unfortunate. Sometimes things like married, not married kids, loans from school, all those things kind of limit their options in terms of how they can practice or what kind of practice environment they can go to. And that's unfortunate because my generation didn't have those necessary, family, yes, but large amounts of student loans. We just weren't able to actually borrow that amount of money, right? And it's unfortunate that many of them are making decisions based on that, which is tough. And I feel for them. Beyond that, I think the decision is how you want to practice, right? Do you want to practice the corporate model, or do you want to practice the private practice model, or do you want to go into academics? And I would tell a young person, if they have the ability to at least try academics, that's not a bad start for a lot of people. And the reason I'd say that is that you're going to get a broader experience in surgical techniques. You're going to have a protective environment that you're going to be able to do these things with. And you're going to be able to gain confidence and experience that you may not be able to get in private practice. And you'll get your name out in the community, right? And it may stick for you. You may say, you know what, I really enjoy teaching, and this is what I want to do. And that's great, because we need our best and brightest to go into academics. If we don't have that, then training of future generations of surgeons is going to be compromised.
Mm-hmm.
So I would tell any young person to at least give that a thought and go through the process and see what's available for you. Then the other decision is corporate model versus private practice. And there's pros and cons of both, obviously. The problem that I see with the corporate model, and again, I'm biased because I'm in that private practice area, is that you're getting paid a decent salary, but you're running from location to location to location, and you could be traveling a lot of miles every week, but you're really not creating goodwill in any particular community, right? So when you do decide to go into private practice, none of that experience is really going to equate to your community that you set up practice in, right? Yeah, you may have experience. It may be good experience or it may be bad experience. Hard to say. Depends on the situation. But at least if you decide to go into private practice, even if you start small, you're creating goodwill within a community. And if you do the right thing, then over time, you're going to be able to build that practice up. And then you're going to be able to reach the same goals that you may have in the corporate world in terms of finances. But, it's a tough decision. I don't know if there's any right path for every individual. I think it depends on their circumstances and what their desires are, right? The problem in private practice is you've got to be a business owner. You've got to hire and fire people. You've got to do payroll. You've got to run an office, right? You've got to run a business. Some people don't want to do that. They're not good at that, or they feel they're not good at that. I had no experience in that, but over 25 years learned, from making mistakes and getting good people around me to help me make those decisions, professionals who are in those particular fields. And I think it can be done, but some people just don't want to do it. So I think those are the issues. The particular issues with the hospital systems is a separate concern. Insurance, and hospital cases are becoming more and more difficult to do. And that's just as the healthcare system gets squeezed. I think, COVID kind of didn't help that. And even in the post-COVID area, the resources available are limited, right? Many clinicians retired. Many people left, particularly urban areas, to go to different areas that are maybe a little lower cost of living, less stress, little more friendly lifestyles. And so therefore there's a shortage of clinicians, shortage of anesthesiologists, for instance, in our particular location, that put, constraints on OR time and how many cases can be done. And so there's reduced resources for surgeons who want to do cases. So there's a lot of extraneous forces on the market that can affect a practice and can affect a decision by anyone coming into any particular location. And I would tell that person to do their research and see which one of those three models might fit best for them.
Yeah. So someone that's in residency right now, let's say as an oral maxillofacial surgeon, has to make a real decision about whether or not they're going to go the corporate route for a period of time.
Yeah.
And pay off some of the debt that they may have accrued.
Sure.
And then try to find their way to a potential partnership. Hopefully they're getting into a practice where they're getting a great mentor, somebody that can really help them and learn all of those things that you had to learn on your own over 25 years. I think that's the benefit of buying into a practice, is that you get to actually get that knowledge. That's why you see some of these guys that stick around. They're not seeing patients anymore, but they're really helping out with the practice still, and they're still involved in the practice because guys need them, you know?
Yeah, I think there's a lot to be said about that. I just think it just depends on the circumstances and the environment and the number of offices and staff. And there's a lot of things that have to go into that decision. But the reality is there's a number of options. And I think that the individual has to just, do their research and see what's best for them. But I don't think that either buying or opening a practice is necessarily a bad thing. I think it's probably the right thing. Because you have control. The problem is in the corporate world, you have no control. Perfect example is what happened to us at John Muir Medical Center. For many years, there was an anesthesia group there who was basically covering John Muir and several hospitals in that 680 corridor. They did a great job. They provided fantastic service for us for decades. They were bought out by a venture capital fund. And that corporation did an analysis of what their anesthesiologists in that location were making. Margin-wise, they didn't think that was a good bet for them. So they basically gave them pink slips overnight and fired, over 120 anesthesiologists overnight. And so John Muir went from a situation where they had full anesthesia care to now having to scramble to try to hire individuals or bring people in. It really turned into a mess, and it dramatically affected the operating room for several years. In fact, still has affected. That was 4 years ago.
It's a ripple effect.
It's a ripple effect, right? And so that's the risk you take when you go the corporate route, is that you have really no control over what your future is. And if that venture capital gets bought out by another company and they decide that they want to downsize or liquidate, then you could be on the chopping blocks. So you may lose that job. And then again, you haven't really developed any goodwill in the community because you've been working in multiple different offices. So it becomes, those are some of the things that I think that people need to consider before they make that decision.
Yeah, it's funny. I mean, we talk about private equity coming in and they're making those, in their world, they have to be blind. Their job is to actually return a greatest return for their investor and get more money to get back out in the market and do that.
That's right.
The downside of that is that a lot of people are affected in a negative way around that. And you hope that there's more of a move to the middle of trying to understand, okay, what is an ethical way to actually approach these types of things? People do great jobs. They deserve to get paid well. And yeah. So, okay. Guys in Blackhawk playing golf, breaks a tooth, goes to the general dentist. You need an implant. What's the one thing he needs to know?
Well, what he needs to know is it's very likely that we could potentially remove that tooth and place the implant in the same day. And with the right coordination, it's also possible that he could get a fixed provisional on that implant either that day or within 24 or 48 hours, depending on the situation, right?
And so just for those that, uninitiated, what does that mean? Fixed provisional, that means that we can...
Basically, it needs a temporary tooth. So, with an implant, you have the implant, then you have an intermediate abutment that connects to the implant, and then you have the tooth that connects to the abutment. And so for patients that have, let's say, a horizontal fracture or even a vertical fracture of a central incisor or lateral incisor, if there's adequate bone, we can remove that tooth atraumatically with, minimal bone and no bone removal. And if there's adequate bone, we can place an implant at the same time. And if that implant is stable in the bone, now we have really great implant systems with high torque, initial torque values that we could use for those cases. So there's a good initial bone stability. If there's adequate bone stability, then the patient can have a temporary tooth put on that implant. So they never have to wear something removable, and they certainly don't have to go around town without a tooth. That tooth is a looking tooth. It's not a chewing tooth, right? They can't chew on it for at least 6 to 8 weeks, but it looks like a natural tooth. And for all intents and purposes, no one's really going to know that they have a tooth that's missing. And then once that implant heals, after a couple months, then the general dentist can then go back and make the final restoration. So some sort of porcelain or porcelain ceramic crown. And that's ideal treatment.
And that immediate placement is going to come down to the amount of bone that's available and then the size of the implant that you can place properly.
That's correct. That's correct. So sometimes, the trauma has not only broken the tooth, but the trauma has also broken the bone, right? And in particularly if it's the front part of the bone, then the patient's not a good candidate for that, because it's unlikely that we're going to be able to get good stability, and we don't really know how that bone's going to react. So in that scenario, we would remove the tooth, do a bone graft to regenerate that bone, and then after 2 or 3 months of healing, we could then come back and place the implant. So the patient can still have an implant. It just means we may have to stage it. But ideally, the bone's not affected, and ideally there's not a lot of infection around the tooth, because this is a traumatic injury as opposed to a periodontal problem. And so for a large percentage of those patients, they could literally within the day or within 24, 48 hours have a temporary tooth place. Sometimes what we'll do is when we place the implant, we will, if the restorative dentist is ready to make a temporary, great. If they're not, then we could take a digital scan of the implant position. We can send that to the laboratory, and then within 48 hours, the laboratory can make a lab processed provisional that either can come back to us to put it in or go back to the general dentist. So it just depends on the scenario, right? The dentist's not available, or they're out of town or on vacation, we can still do it. It just means we have to delay it a day or two.
One of the things I love about hanging out with you is I learn something new every time over all the issues. It's funny. I was just thinking as you were talking about the infection side of it. Well, you could have an infection prior to that made the tooth actually fail.
Exactly.
Or you can have an infection post that could affect its ability. So when you're managing these cases, having that experience is so, so valuable. I think about it, I go, if I was going to have a dental implant, I know exactly where I'm going. And if I do have a daughter that needs to have her wisdom teeth out, I know where I'm going for that too.
Well, we appreciate that. That's very kind of you to say. But again, it gets back to options, right? And patients have to understand what their options are, what their risk profile is, and be part of that decision process. But we have so many more options nowadays than we had even 10 years ago or 15 years ago. Certainly 30 years ago, we didn't have those options. And so the technology, our understanding of how implants heal, and our techniques and also our materials are so much better now. What I'm doing today, I wasn't doing 3 years ago. I just can barely imagine what we're going to be doing in another 3, 5, 10 years from now, right? So it continues to get better, and that process continues to improve patient outcomes. And that's really what it's all about. We want the best patient outcomes we can get.
All right. So we've talked about all of things clinical. I don't think we can cover anything more unless you can come up with something.
I think we've run the gamut on that.
So let's talk about fatherhood.
Okay.
We have a similar situation, both boy and a girl, 2 totally different experiences raising, just
very much so.
Yeah. I'm glad. I love having the daughter. It was just an interesting experience compared to the son.
And my kids are in their 20s now. One's almost 30, and we're still kind of raising them. So it never ends, right?
It's funny. I was having a conversation with my dad over the weekend, and I realized, hey, I'm 56 years old, and I still I'm so grateful to have that.
Yep.
Of course, I have a lot of friends who are older than I am that can give me a lot of insight, and there are different times I call different people to talk about things. But being a dad,
best job in the world, by the way.
It's really amazing, isn't it?
Yeah, it is. It is amazing.
For the young father out there, what are the things that are most important?
Yeah, that's a great question. And I feel like I have a good handle of oral maxillofacial surgery. Fatherhood, questionable, right? So it depends on who you ask. I think what worked for our children is to be present as much as possible and to be that supportive hand. Whether you wanted to be at that baseball game or that soccer game or not is kind of irrelevant. The fact that you were there and showed up and were present, that's really what matters. And I think that I look at how my kids were raised, and I looked at how I was raised. It's almost like night and day, right? the challenges and the demands are so much more greater now with social media and everything that goes on. The level of anxiety and complexity of relationships is so much different, right, than when we grew up. I'm a little older than you, but similar time frame.
Well, we didn't have phones and we didn't have social media.
We didn't have any of that. We had the dial phone, right? So I think that's something that every parent needs to take into consideration. You got to make a decision how you're going to manage that. Denying it or just saying, oh, let them do what they're going to do, that's probably, I don't feel is the best option. I think you got to have to manage it some way or the other. And you have to kind of reduce their anxiety about situations that arise and refocus on what's important in life. Okay, whether that be interpersonal relationships, whether that be religion, whether that be, family, whether that be sports, whatever it is that you can refocus in a positive direction, as opposed to what oftentimes works into a very negative direction and creates a lot of anxiety for those kids and really kind of gets them off path. I think that's important. And again, I'm not saying that we were able to do that all the time, but we tried hard.
Well, it's a process of failing forward, I would imagine, right, for every parent. Listening to you, it's clear to me, that you had kids that were looking at a father, and those are big shoes to fill. Did you feel like your kids felt a lot of pressure to live up to the standards that you had set, which were so high?
Yeah. I think I had pressure with my parents as well. And I think every kid that has parents in their life probably feel that pressure one way or the other. But, you try to mitigate it, right? You try to channel it in a positive thing. Now, I brought both my kids into the office to show them what oral surgery was. Neither one of them were interested. And, I was like, yeah, okay, that's fine. You got to find your path. You got to find what centers you and what gets you out of bed every morning that you want to do. I think that's important, right? I can't tell you what that is. You have to find that on your own, right? It's a work in progress, right? It never ends until someday, I guess it will, but it's a work in progress.
Last thing is to talk about, you've been married a long time.
Yeah, I have been. Yeah, we're going on 34 years. Yeah.
34 years. Yeah. That's quite an accomplishment. That's 10,
appreciate that.
10 more than me.
Yeah.
What's the secret?
Yeah, that's a good question. I mean, like I said, again, I'm no expert in relationships, that's for sure. I think a lot of it is respecting that individual and making them feel like they're part of a team, part of a family, and giving them space when they need it and being supportive when they need it. I think that goes a long way. Yeah, I think that goes a long way. Beyond that, I can't give any other advice regarding that. This is something that's happened. 34 years went by very quick. I can tell you that for sure. Really quick.
Right. I was talking to somebody yesterday, and I was going to be in some place that was, close to my youth. And I almost was like, oof, kind of takes your breath away.
Yeah.
Because, those days are long gone.
Right.
And it's interesting.
Yeah. I had that experience when both my kids played high school sports. My son went on to play in college and the pros. But when I would go to my old high school, neither one of them went to my old high school, but they were in rival high schools. So we'd go there to watch games, and I'm walking around the hallways going, wow, this brings back some memories, right? I remember as a little, kind of as a teenager running through these hallways, and you pause and think about that, right? So
yeah, it's amazing how fast time flies.
It goes by too fast.
And the people that tell you that when you're in the middle of it, and you go, just can't imagine.
Can't imagine.
You just have to limit to do it. It's like the people used to say to me, oh, your kids will be, in college before you know it. I'm like, right. I mean, the little kids, right? And now
now you wish you were little kids again, right?
Sometimes. I mean, for me, it was, sometimes. I definitely don't think, like you said, I'm not wired. I was just blessed with a wife who was really wired for childcare because I was a guy living on airplanes and traveling around doing my thing.
Yeah, no, I know. I was a guy spending most of my time in the hospital or on call. So So yeah, I know exactly where you're coming from, and you just have to make those times that you do spend with them special. That's the point.
Yeah. One clinical thing I didn't ask you, how many dental implants do you think you've placed?
Oh gosh, it's well into the thousands. I
Yeah.
mean, but it's probably 10, 12,000 implants. Yeah, over the last 30 years, 35 years. That's a lot.
Yeah. A lot of implants.
Yeah.
I mean, and to think about that, how many implants do you think you placed in Walnut Creek in private practice?
Oh, the last 25 years? Yeah, I'd say probably 8 or 9,000, probably something like that.
Wow.
Quite a
8
lot.
or 9,000 patients.
Yeah.
When patients have a dental implant, do they come back? How often do you think you see them?
Yeah, so we see them once we've tested the implant to make sure it's stable and healed, and we send them back to the dentist. We'll see them 6 months after the final crown is placed, and we'll get a screening X-ray to make sure everything's good, make sure that the tissues are healthy, make sure the bone's healthy, and then we see them at that point on an as-needed basis, right? Because at that point they're going back to the general dentist. They're being seen every 3 to 6 months for their hygiene appointments. When there was any issues, we have a good referral source, so they would send them back to see us. But we don't really see too many that come back. Some of the older implants, when I say older implants that I did, 20 years ago, 25 years ago, are having some problems. And there were some implants that hit the market that the surface topography of that implant made it more likely to develop bone loss, or what we call peri-implantitis. And again, it's not as a technique issue or necessarily a patient healing issue. It's a mechanical issue of how that implant was designed. And we've learned a lot from those failures, right? And so I still will see on occasion patients that will come back, but it's rare now to see that because we've pretty much, retreated those patients.
Yeah, I mean, you look at how implant technology you think about it, you go, oh, well, how much could it actually change? How could it get better? How could it actually, well, it's the way that it's, milled, and the new way that the angle is, and the coatings and all that stuff. It's just.
And it's beyond that too. It's also the restorative aspect because implants typically fail for one of two reasons in the vast majority of cases. Either there's a problem with the bone, either the bone's too hard or too soft and the implant just has overloaded or fails as a result of bone loss, or if the restorative aspect is not done correctly, right? So abutment choice, screw choice, very important. Material choice, very important. Occlusion, very important. So all of those things come into factors. So you'll see failures from two different aspects. And as a surgeon, what I would tell a young surgeon trying to develop an implant practice is oftentimes surgery, we're focused on techniques. We're focused on healing. We're focused on new bone graft materials or new soft tissue grafting procedures or new implants. But we're not as focused on working as a partner with our general dentist or our prosthodontist to try to get best restorative outcomes for patients, right? And so that collaboration between surgeon and restorative dentist is really critical if you're going to have a successful implant practice. And I have a study club that I've run for the last 15 years through Seattle Study Club, and it's basically an implant restorative study club that we invite our dentists to participate in. And we bring in lecturers and we present presentations talking about that implant restorative connection. There's two advantages to that. One is you bring your restorative doctors up to a level that's standard of care and is very progressive to reduce those failures. And second of all, you create a ability to communicate. So if there is a problem or failure, you can communicate and figure out what needs to be done, as opposed to the surgeon seeing a patient with a broken screw and say, well, you go back to the restorative dentist. The restorative dentist sees the patient, sees the loose crowns, and they say, go back to the surgeon, right? So now the patient is confused. Where's the problem? Who's going to take care of it? That's what they want to know, right? So creating that type of connection with your restorative doctors is important if you're going to be successful at implant surgery. And that's not intuitive because we don't learn that in oral surgery training. We don't learn that in medical school or in dental school necessarily. You got to learn that by reaching out in your community and creating those interpersonal relationships and treat patients collectively. And that would be probably one of the things I would tell a young surgeon to try to do.
Yeah, and that's the foundation of that is education and then being able to speak the same language.
Correct.
Yeah, I mean, if I'm distilling down what you're saying, the pathway to peak performance on that particular portion of it is the ability to have a baseline understanding of what you're working with, and then this nomenclature of how you're going to communicate with each other.
Correct.
So that it's repeatable.
Right, correct. So when I go to lectures, and I still go to lectures, I get more out of watching the restorative lecturers talk about implant restorations and soft tissue management and implant materials, as opposed to necessarily the surgical techniques. It's not that I don't gain pearls and wisdom from watching those lectures on surgery, but I gain much more about how to manage my surgery and how to deal with complications and issues that come up when I see those restorative lectures, because now I understand what the general dentist is dealing with and where the pitfalls are. And so now I can communicate with them, try to bridge that gap, right? So the idea is to be collaborative. The idea is not to be, here you go, here's the implant, it's in bone, it's healed, good luck. That's not the way you're going to build an implant practice.
Yeah, it's so cool. One of the things that also occurs to me that's so interesting about something that we have in common is you went back to where you're from. So did I.
Yeah, right.
And what's it like to be in Orinda, Walnut Creek area and service a patient base there for 25 years? I mean,
Yeah.
What's it like?
It's great. I mean, it's a very fortunate, it's a fantastic community. And it's that great mix of educated people that understand the need for treatment, right? And so we're able to do a lot of great things for patients as a result of that. So it's been great. But coming home was a real treat for me, because again, I lived away for almost a decade, and it was nice to come home. And both my parents have passed now within the last couple of years, but it was nice to be there as they went through that process, and still have a lot of relatives that are very close to. And so it's nice. There's no doubt about it.
We're blessed in the Bay Area with a lot of sports teams that are just phenomenal. Like we can just look at Steph Curry, just like he gets into this flow state of just shooting, three-pointers. When you're doing what you do in a surgical setting, very complicated. It's not just you. Steph Curry needs, teammates to set him up to get.
Absolutely.
But how do you get into that peak performance flow state?
That's a really good question. And I think, there are so many different products and ways of doing things out there. It can almost be overwhelming and confusing, right? And for me, I like predictable. I like predictable results. When I do a case, I want it to be perfect. I feel like I strive for that. And I want, when that patient goes back to the referral dentist, for them to feel the same way. Because what I want is for them to have an easy experience, right? I don't want them to have to struggle. I don't want to have them work more difficult with their and increase their costs in doing the care to the patient because of a malposition implant or soft tissue problems or whatever. So what I do is I leverage technology. And so for every patient, we're doing cone beam CT. For a lot of patients, we're doing CT guides. Not all patients, but for a lot of patients, we're doing CT guides. And we're doing soft tissue manipulations, we're doing bone grafts, and we're doing connective tissue grafts when they're indicated. And so each case, I identify what needs to be done, and then we execute it. And that execution is what makes the difference, right? So we're not trying to reinvent things. We're not trying to experiment on patients. We're just say, we know what works in this particular case, in this particular scenario, and this is what we're going to do. And if you get to that point, then it can be very efficient, and, it can work out really well. But it takes time to get to that point, right? And that's what I see with a lot of young surgeons is they get, they go to a class and this person's doing it this way, and they read a book, the person proves it that way. And that's all fine and good, but you got to figure out what works for you and what works for the individual patient that you're treating at that point. That's what we try to do. We try to make it as efficient as possible, and we try to streamline the treatment, because we also have to understand that, patient's time is important, right? So you've got to create a mechanism for reducing that patient time, but getting equal, if not better outcomes, right? So material selection, how you stage patients, when you do bone grafts, all of those things make a difference. So I think that comes with just experience.
So I don't want to put words in your mouth, but it sounds to me like you're getting into a flow state by running through your checklist, knowing that you've got everything that you need to do that case the right way lined up before you ever start
Absolutely.
And that allows you to have that. I think anybody just doing anything that's important, you have to have a confidence in your capabilities,
No doubt.
and then know what your purpose is, your outcome, that you're already thinking outcome before you've ever started.
That's right. You got to think where you want to go before you can go there, right?
Mhm.
So if you don't know what you're trying to achieve, and again, that comes down with the communication with your restorative dentist. If you're not on the same page, how are you going to ever get there? It's hit and miss, right? So you got to work back, or you got to say, what are we trying to achieve here? So let's work back and see what we can do to give that patient the best outcome in the most efficient way possible and the least expense possible, right? I mean, you can throw everything at every patient and run up their bills, but that doesn't necessarily mean they're going to have better outcomes, right? The way you make that work for you is that patient's happy and they come back for additional treatment, or they refer their family and friends. That's how you do more implants. You don't do more implants, trying to do more implants at one particular time.
Yeah.
So that's kind of how you build that practice. And efficiency is very, very important. And I'll tell you a funny story. I mean, not really funny, but in prior days, when we first started doing implants, we were waiting 8 months, sometimes 12 months before the implant. We would test it to see if it's integrated. Then we went to 6 months. But still, at 6 months, you put an implant in, you see the patient back, you test it, it's good. Now the patient has to call the general dentist to make an appointment. Well, that could take a week. It could take a couple of months, depending on how busy they are. So now the patient has to wait for that appointment to get an impression. That has to go to the lab. So now you're delaying it another week, a month and a half. So that whole process is now, no matter how much time you put into it, is much longer, right? So I had female patients come back. I'd say, when I see them at 6 months, how do you like your crown? Oh, Dr. Karas, I love the crown, but you know what? I had a baby quicker than I was able to get a tooth back, right? It's like, well, that's not good. So we gotta change our thought process here, right? So how can we get to the point where the implants are healed within 2 to 3 months, and how can we then get that information to the general dentist or restorative dentist to start making the crown? So that's when we integrated the iTero scans and the digital scanning. So when we do second stage procedure for a lot of our restorative dentists, not all, because some still wanted to do that, we would take a digital scan at the time we do second stage, and then we would send that to their lab of choice, right? And so within a few days, that information is at the lab, and so now the lab contacts the dentist, and they give them a shave. They let them know what type of abutment and what type of material they want for the crown, and now within 10 days, 2 weeks, that crown is ready to be placed, right? So now we've taken that 6 or 8 month process now down to 2.5, 3.5 months, somewhere in that time frame. And when you put it in that perspective, patients are like, "Oh yeah, no, that sounds reasonable. I can wait that amount of time."
Vastly superior.
Vastly superior, right? And when you tell a patient it's going to take you 6 to 9 months, sometimes 12, to replace a tooth, they look at you like, "Really? I mean, come on. We're in 2025 now. I mean, is that really realistic?" You're like, well, you can do it that way. It works. There's nothing wrong with it. It's just, maybe it's just not like Curry. He's not going to wait to take that 3-pointer. He's going to take it right then and there when he has the opportunity. It's kind of the same situation, right?
Yeah. Really interesting to think about, like, the going back to what we talked about, the level of communication. I mean, this is a master class for anybody that's starting to do practice. Like,
Yeah.
I almost want to send this out to the entire oral surgery market, just for them to hear it. But, the reality is that, that level of communication has to be there in order. I often go back and I listen to these episodes. Every time I listen to them, I hear a completely different episode.
Hmm.
Something that I just didn't
Yeah.
hear in the first one. I think, it's that whole notion that the brain can't hold two thoughts at once, and there's going to be something that comes in you're going to think about as well as something's being said. What's interesting is I kind of counted out the points of contact that have to happen between you and a restorative partner to really make that work the right way, and you have definitely mastered that. That's something that, I wonder in the future, do you ever think that you might teach that?
Yeah, as I'm getting older, I'm starting to think about what what my path will be, and I haven't quite figured it out yet. But I wouldn't mind going back into teaching. It would just have to be the right situation, and it would have to be something that I don't want to be so invested in it like I was before, that it takes over my life, so to speak.
I'm just thinking like the Karas method of like, total practice management and all that kind of stuff.
No, I think there are other people that are probably would be able to do that better than me. I'm not.
There's that humility again.
Yeah. So I'm not sure I have much to offer from that standpoint, but anyway, I don't know. We'll see.
One of the things I love about talking with you is we could just go on and on. I always feel like that whenever I talk to you, I could talk to you forever. I don't know if you feel the same way about me, and don't tell me because
Absolutely. We always have good conversations.
Yeah.
It's always a pleasure.
And you're a champion. And you know what? Somebody I really admire, and it's a pleasure and an honor to know you. And I just want to thank you for coming in to spend some time with us.
Yeah, I feel the same way. We appreciate, all of your direction over the years, and it's been a great relationship. We want to continue that.
Hey, thanks everyone for watching the show. Please remember to like, comment, and subscribe. It really helps us out here at the channel, and share the video with someone who might be interested in supporting the charity that our guest mentioned in the episode. Thanks again. We'll see you soon.